This is a patient with a history of trauma to his right eye. He developed a traumatic cataract and a fixed, dilated, atonic pupil. He is suffering from chronic glare. He had extensive YAG laser capsulotomy, and now he has an Agrosoft implant with significant scratches in the center of the optic. We have made a decision to exchange this implant and to do an iris cerclage. Because of the extensive capsulotomy, it is difficult to viscodilate the bag open as there is no backboard to create pressure against, so the lens has to be carefully dissected out of the capsular bag using micro hooks. Here we're bringing the temporal haptic up out of the capsular bag, and we're going to cut it using an MST scissor. We can now bring the optic up out through the anterior capsule, and we will cut the nasal haptic using an MST scissor designed for this purpose as well. Here's the MST haptic cutter being used to amputate this haptic, and now we can easily cut the optic in half and remove this. I'm going to cut the optic about 90% of the way through, and then I can cartwheel it out of the incision without enlarging the incision. After the lens is removed from the eye, two pars plana trocars are going to be placed and a pars plana vitrectomy carried out. I'm not really sure if vitreous has presented through the open capsule at this point, but I've made the decision to do a vitrectomy to eliminate that possibility. After the vitrectomy is carried out, a Bausch & Lomb soft port silicone 3-piece lens is injected into the ciliary sulcus and then rotated completely into the sulcus, and then this will be optic captured. Because the rexus is somewhat small, we're using micro hooks to retract the rexus while we pop the lens into position behind the anterior capsule. Once the lens is in position, we can start the iris cerclage. Here I'm going to use an Ahmed micro grasper to gently tug on the iris, and once that is done, a tenoproline on a CIF4 needle is going to be passed through the iris, and then a baseball stitch is going to be done 360 degrees to perform the cerclage. And here I'm adapting a technique that is very similar to the one used by Ahmed for iris cerclage. In the past, I used to do partial thickness bites, and although this provided a good cosmetic result, in some cases the tenoproline suture would cheese the wire through over time. So I've adapted this method of using a full thickness bite, 360 degrees, in a baseball stitch, which I think is a very nice way to do this. The key here is to use your right hand to stabilize the needle and your left hand with the micro grasper to drape the iris over the tip of the suture. Once you have as many bites as you can comfortably place close together over the needle is passed through another paracentesis by being captured in the lumen of a 27 gauge cannula, and then it is brought out using a Sinskey hook to prevent the iris from coming out the paracentesis. When we go to the second 90 degrees, I'll switch hands and use my left hand to hold the needle while the right hand drapes the iris over the tip of the suture, and you're really just stabilizing the needle with the needle holder and using the second hand with the micrograsper to do most of the work. And you're winding the iris around the tip of the needle in a baseball stitch full thickness. Um, After multiple bites as close together as possible are taken, the tip of the needle will be brought out through a paracentesis 90 degrees away. We'll use a 27 gauge cannula to capture the tip of the needle once again. In this case, it is a little bit more difficult because this eye is a little bit soft as it has been vitrectomized. And when you pass the needle here, I'm using the other half of a double-armed 10-0 Proline. You have to be very careful not to catch any corneal stroma, otherwise the suture will get hung up. It is a little bit difficult here because the pars plana trocars do get in the way a little bit, but they can be worked around. I do need the infusion line here to keep the eye from getting too soft, otherwise I will lose control. Again, here I'm using my right hand now and using the left hand to drape the iris over the tip of the needle. Once I have enough bites, I can use the 27 gauge cannula to capture the tip of the needle. And now we're going to finish the cerclage and use the last 90 degrees. Um, I'm using my left hand to drape the iris over the needle from a position where it's comfortable for me ergonomically. And it's very important when you do these procedures to get yourself in a good ergonomic position where you're comfortable. Again, here I am having a little problem because the back of the needle is being interfered with a bit by the pars plana trocar, but not so much that I can't do the procedure. Um, if I couldn't do it, I would have removed that trocar at this point. Um, Here there is a little bit of bleeding as the patient moved a little bit during this part of the procedure, but it's minimal. Once the last suture is passed through the iris and captured, we tie a triple throw, and once this is tied, the knot will be internalized and grabbed internally with a 25 gauge micro tire. And with this inside the eye, we can pull on the two ends of the suture and adjust the tension very nicely. I want to make the size of the pupil about 3.5 millimeters, so the retina can still be visualized, but this looks physiologic and similar to the other eye in normal lighting. Again, a second throw and a third throw are placed, and the tension is adjusted to adjust the size of the pupil. After a throw is made, the knot is internalized and tightened internally by pulling on one side while the other side is pulled externally, and this gives very nice control. A micro scissor can then be used to cut the suture short inside the eye. Viscoelastic is removed using separate irrigation and aspiration hand pieces. This is done with relatively low flow to not traumatize the iris at this point. The trocars are removed and the case is completed.